This lecture, entitled Anxiety and Adjustment Disorders in Cancer Patients, is one webcast of the multilingual core curriculum prepared and presented by the International Psycho-Oncology Society with the generous support of the European School of Oncology. The webcasts are provided for the education of oncologists and other physicians and healthcare professionals involved in cancer care. These webcasts are provided on both the IPOS and the ESO websites. This lecture was originally written and presented by Dr. Katalin Muszbek, Medical Director of the Hungarian Hospice Foundation. This presentation will discuss anxiety and adjustment disorders, two of the most common psychiatric disorders in cancer. After discussing special aspects of these disorders in cancer patients, this lecture will present psychological and psychopharmacological methods to help cancer patients deal with adjustment disorders and/or anxiety. Welcome to the IPOS online curriculum. This module provides you with information about anxiety and adjustment disorders caused by cancer. You may belong to those persons who regularly deal with cancer patients. You can realize in your practice how difficult it is to be diagnosed with cancer. For most of the patients, it means suffering, pain, and the threat of death and dying. Patients might be anxious, distressed, depressed, and sometimes hardly able to cope with the disease. Throughout this lecture, there are several objectives. First, to understand the impact of anxiety and adjustment disorders on cancer treatment. Second, to know something about the symptoms of adjustment and anxiety disorders in cancer patients. Finally, to have a sense of the most commonly used means of psychotherapy and pharmacotherapy, and also to understand the evaluation of anxiety and adjustment disorders. All in all, this module can help you better understand these psychological phenomena and draw attention to them. For many patients, cancer is a stressful, traumatic event. Your clinical observations underscore the data from studies relevant to our subject matter. Shock, disbelief, numbness constitute a frequent initial response. Sometimes the response may be an immediate sense of despair and hopelessness. This might be followed by dysphoria, irritability, anxiety, and depression. These states may entail a loss of appetite, difficulties with sleep, an impairment in concentration, and impairment in maintenance of activities of daily living. All these might be coupled with intrusive thoughts and fears. For most of the patients, these symptoms resolve in about 7 to 10 days. There are three major factors that might have an impact on the psychosocial adjustment to cancer. The level of distress might be influenced by medical factors like the site of the tumor, stage and course of the disease, prognostic factors, pain, and physical symptoms. The different forms and side effects of the treatments for cancer can also influence the level of distress. The second group is related to the personality of the patient, to past experiences, to his or her coping mechanisms, and events in his or her current life period when cancer is being treated or diagnosed. Social environment, attitudes and beliefs, means of support available, partner, family, community resources belong to the third area. Levels of distress are much higher if the patient has too few or insufficient psychological, personal, and social resources. When a person with poor resources develops a severe illness, the likelihood of significant psychological disorders is very high. A great number of them are in need of psychological support. Peter is 72 years old. He has prostate cancer. He lost his wife 2 years ago. He had been retired for about a year. He was a journalist, quite active, working as much as 12 hours a day. His job was highly recognized and he was quite acclaimed. When diagnosed with cancer, he felt lonely and quite depressed. He had no plans for the future. He was focusing on the wish to die. He seemed helpless, hopeless, with no effective coping mechanisms. Almost no means of support were available, since he had no children or family. When referred to psychotherapy, his level of distress was very high. Level of distress may vary greatly during the different phases of cancer. As you see in this graphic that describes the phases of distress in cancer, there are initial and subsequent points along the way in which we can expect patients to have increases in their level of distress. Beginning with diagnosis, beginning with treatment, the completion of treatment, recurrence of disease, as a person enters palliative treatment, as disease advances, and as people approach the terminal phase of their illness. These are all points in which increases in anxiety and dysphoria are common and to be expected. When the diagnosis of cancer is made, the patient's whole life undergoes a drastic transformation that affects his or her emotions, his or her family life, his or her sexual life. In this phase of the disease, patients might have a feeling of fundamental fear that leads to high levels of distress. Fear is most commonly associated with a life-threatening disease, including fears of death and suffering, fear of mutilation or disfigurement, as well as some side effects of the treatment and an overall fear of the unknown. Moreover, the illness itself creates a problem of control. For many people, the sense of autonomy, self-control, feelings of being important and useful are crucial. There are periods in the progression of the disease, particularly the advanced stage, that bring out the feeling of diminished control and the fear of being abandoned. Like all life-threatening diseases, cancer has a significant impact on emotions. We do know about quite a few psychiatric and psychological symptoms described in the literature and case studies. The most common types of psychiatric disorders are anxiety and depression. A number of studies were published in the last decades on this topic. One of the most popular and often quoted study is the one from Derogatis and his group that shows the prevalence of psychiatric disorders in a diverse group of ambulatory cancer patients. Nearly 50% of those cancer patients studied had a psychiatric diagnosis, and most of them had reactive depression, adjustment disorders. A smaller number had other disorders, including delirium and anxiety disorders. So many of the patients that you will see who have cancer and have a psychiatric disorder will probably have an anxiety or an adjustment disorder. Cancer patients have to face an enormous stressor, and that is the diagnosis of a life-threatening disease. Most of the patients show a normal reaction to this news with no overt manifestations of psychological maladaptation. About 21%, 5 to 42% in different studies of cancer patients, though, do develop clinically significant emotional or behavioral symptoms. Adjustment disorders are intermediary psychological states between normal response and signs of major mental disorder. In the DSM system, adjustment disorders allow for us to label what are really subthreshold mental states, whether they are anxiety or depression or a combination of the two. They are characterized by maladaptation in one or more psychosocial spheres, including work, interpersonal relationships, activities of daily living, and enjoyment of life, along with anxiety and depression. Symptoms are regularly not very specific and resolve within 6 months. If the illness lasts longer than 6 months, the psychiatric disorder related to stress may persist as well in a chronic form. How can we diagnose adjustment disorders in our patients? The first element of the diagnosis is the stressor, in this case the news of having cancer. There are maladaptive reactions to the stressor, like emotional or behavioral symptoms, anxiety, dysphoria. There cannot be a coexisting axis 1 disorder such as major depression or bipolar disorder, and according to the DSM system, it cannot be a response to bereavement. The primary means of reducing distress is psychotherapy. For most patients, counseling or supportive psychotherapy might be most effective. In some cases, like extreme distress, sleeping disorders, pharmacotherapy interventions might be useful as well. We might use short-term benzodiazepines and hypnotics to help relieve these symptoms. Many patients have to face the onset of the recurrence of the disease. It is necessary to understand and interpret the meaning of the disease, the capacity of the patient to cope with the current situation. It is also important to clarify negative thoughts many patients might have. They do not necessarily have to do anything with death at all. As a result of psychotherapy, patients might learn how to monitor and change their own thoughts. They might also adopt certain behavioral strategies that help them lower their level of anxiety and distress. These means can be very effective. Psychotherapeutic support might as well focus on patient's partner or family. This might help them learn to identify and modify interpersonal conflicts that may be exacerbating their level of distress. In the phase of diagnosis, group therapies might be very helpful as well. Here, patients with similar problems get a chance to meet and identify common problems and reduce their psychological distress together. However, adjustment disorder is considered a transitory state. It is very important to continue to monitor for the development of a major psychiatric disorder such as major depression or generalized anxiety disorder. These may develop as a result of protracted periods of the stress. The most difficult phase for cancer patients is where they have just been given news about either the diagnosis of cancer or recurrence. In this stage of disease, patients prefer to share their feelings within the frameworks of an individual psychotherapy. This situation gives the patient a feeling of comfort, the certainty of being respected and appreciated. In this situation of crisis, a selective intervention might be helpful in managing the level of distress. The crisis due to cancer may lead to emotional regression. This is the reason why it is useful to help the patient remain in the here and now, in the present, and deal with what is happening at this particular point in time. When patients are anxious about their uncertain future, it is very helpful to remind them to stay in the here and now and work on solving problems in this particular moment. On the other hand, it is necessary to be able to manage unrealistic wishes. Do not promise patients that you're going to be there throughout the entire treatment, but promise them that you are going to help them get the treatment that they need to help them lower their level of anxiety and distress. Many patients need to express the emotions that they feel, and it is very helpful to allow them to do this at this particular time, rather than just to stop the expression of their affect. Also, it is important to avoid statements such as, "I know how you feel," or "it will all be okay," because for most of us working with these patients, we do not know how it feels, and we certainly cannot tell them that it will be okay. And lastly, it is important to focus on realistic rather than negative or positive thinking. So rather than telling patients it will be all okay and to think positively, to focus on the realistic, which is you're getting good care, you have a good doctor. There are few diseases that are able to precipitate as much anxiety as cancer. Anxiety is a subjective phenomenon. During the course of cancer, patients are in a situation where they have to face a lot of stress, losses, fears, along with feelings of insecurity. Anxiety might be a normal reaction to a life-threatening disease, and its symptoms usually resolve gradually in about 15 days. If symptoms persist and cause impairment, it is considered pathological. There are some very stressful periods during the course of the disease which might provoke anxiety. Waiting for the diagnosis or for the result of a control check is typically such a situation. The reason a patient might feel anxious might be a painful diagnostic test such as a bone marrow puncture or the fear of chemotherapy and its side effects. Anxiety is at its highest when therapy proves ineffective and the patient finds him or herself in a situation of total uncertainty. In addition to this, his treatment might be terminated. Because anxiety is a subjective phenomenon, it is very difficult to assess it. It is particularly difficult to evaluate severely ill patients where the symptoms of anxiety overlap with the symptoms caused by the disease or the treatment itself. Data on the prevalence of anxiety is ambiguous. However, studies show that it is about twice as common among cancer patients as among control persons. The prevalence of anxiety ranges from 12 to 28% in different studies. Anxiety is often coexistent with depression. We may expect a high correlation between the symptoms of anxiety and those of depression. States with mixed symptoms are in fact more common than those with anxious symptoms alone. Anxiety may appear in various forms and at various levels of intensity during the course of cancer. The first reaction following the diagnosis of cancer is similar to the ones triggered by other traumatic events. Denial of the disease, feelings of anger towards the environment, and stress are common reactions in this situation. Many patients think of the disease as a violent assault on their body. This in turn might generate apprehension and despair. Throughout the entire course of the disease, anxiety might come up in various shapes and forms. Acute anxiety usually appears in special transitory periods. Anxiety might, however, become chronic and persist for a longer period of time. It might be coupled with special symptoms like phobias, compulsions, or paranoid delusions. Underlying these symptoms, we usually find psychiatric problems in the patient's anamnesis. Julia, 60, was diagnosed 2 years earlier with a bladder tumor. She started treatment with great trust, hoping that it would lead to her recovery. The side effects of the treatment had, however, shattered her. Her hair had fallen out. Later, she accepted to wear a wig. She used to work as an engineer at a research center and retired just a year earlier. Through the retirement, her living conditions had changed as well. The disease thus came at a time when this active person had retired and had just went through changing her residence. Strong mechanisms of defense, first of all denial, helped keep away the reality of disease from her consciousness. The psychological symptoms, strong anxiety above all, followed the recurrence of the tumor. When she became aware of the fact that she had not recovered, at the time she asked for psychological help, her main symptoms were insomnia, worry, dysphoria, crying, and emotional lability. In the course of a 10-session psychotherapy, we have talked through her current situation, the background of her anxiety, her overall attitude towards her cancer. She rejected all medical treatment but cooperated with psychotherapy. She felt it was important to have someone to share her feelings and fears. We managed to lower her level of anxiety significantly in the course of therapy. The first symptoms of anxiety are usually related to diagnosis. Patients become anxious and bothered by unpleasant thoughts. Patients are transfixed with a life-threatening disease and the thought of death. They are afraid of the suffering and pain as well as the side effects of the treatment. Accompanying somatic symptoms might appear as well. Acute anxiety might come up in certain phases of the cancer course. It is likely to appear at the time of regular checkups due to the possibility of adverse results. Another wave of anxiety might follow the development of cancer and the appearance of a metastasis. A further stage of the disease when anxiety is to be expected is the start of a new treatment. At this time, the fear of side effects and the progression of the disease are typical. Paradoxically, anxiety might increase at the cessation of active treatment. Patients, although relieved from aggressive and intrusive treatment, lose the sense of security and control provided by the medical staff. Many of them might be troubled by the thought of having completed medical treatment. Intensity of anxiety varies greatly throughout the course of cancer. Chronic anxiety is typical in the inactive period of disease. Patients without a tumor are often afraid of possible recurrence. In this case, even an infection brings the threat of recurrence and thus activates the patient's anxiety. Anxiety may appear in the form of panic attacks accompanied by intense heartache, shortness of breath, and somatic symptoms. This is the so-called Damocles syndrome, or sword of Damocles syndrome, that is characterized by anxiety, fatigue, insomnia, as well as loss of appetite and restlessness. This syndrome very often persists in the time following the active period of the disease. The negative results of regular checkups allow only temporary reassurance. Many patients experience a diminished sense of self-control. They also feel a growing insecurity concerning their future, as well as a fear of holding down a responsible job. Chronic anxiety is often coupled with losses and with the altered living conditions of cancer patients. Certain special psychiatric symptoms may come up in the course of anxiety, especially in those cancer patients who have already got a history of psychiatric treatment. PTSD may reactivate at the diagnosis of cancer or may develop in the course of the disease. About 40% of cancer patients with symptoms of anxiety did have a pre-existing anxiety disorder. Patients with pre-existing panic disorder often have a recurrence of this disorder when cancer is diagnosed. Symptoms may appear with or without agoraphobia. Claustrophobia represents a significant obstacle to hospitalization, radiotherapy, or special examinations like MRI. Phobic symptoms are usually related to cancer or its treatment. Phobias might be connected to needles, blood, physicians, or the hospital itself. Considering that this is a major reason for many patients to cease their therapy, phobic symptoms are best treated in the earliest possible stage. Due to the effects of cancer, patients with a hypersensitive personality might develop mistrust towards the treatment or the medical staff. In this case, inadequate thoughts, like paranoid overestimations, might appear along with anxiety. Paranoid symptoms accompanied by anxiety might lead to the termination of treatment as well. Symptoms of anxiety might be physical or behavioral. Physical symptoms may include palpitations or tachycardia, choking, lump in the throat, numbness in the limbs. Heavy sweating, dizziness, trembling, easy fatigability might be coupled with a loss of appetite, nausea, diarrhea. It is, however, often hard to tell whether the above symptoms are a result of anxiety, cancer, or its treatments. Psychological symptoms may include stress, despair, emotional lability. Patients might struggle with intrusive thoughts that conjure up the threat of death and dying. Many patients feel helpless and hopeless, which is very hard for them to tolerate. They may be restless and hardly able to sit still. They often suffer from insomnia, nightmares. They might wake up tired and exhausted. Symptoms of anxiety might be intensive, enough to detain treatment. Therefore, it is absolutely important to recognize and treat them in the earliest possible stage. Anxiety should be treated within the context of oncological therapy and should be integral to it. Recognizing anxiety as early as possible is the basis of an effective treatment. The medical staff often underestimates the significance of anxiety, which may delay the beginning of treatment. Giving patients information about the disease helps lower their level of anxiety from the start. Patients feel increasingly anxious after learning about diagnosis. However, informing the patient about treatments, its side effects, future perspectives may ease some of the patient's worries. In the long run, this might have a favorable impact on anxiety in general. Another way to reduce the patient's initial anxiety is to unveil the rational problems that may lie behind it. Family problems, social and existential fear constitute a frequent basis for anxiety. Understanding these problems and dealing with them, offering emotional support, might help to lower patients' level of anxiety. Symptoms of anxiety are best treated in a complex multimodal fashion. Sometimes applying one of the possible methods is sufficient. Nevertheless, due to the special nature of the disease, various components of a multimodal treatment might be required in the course of cancer therapy. The treatment of anxiety might involve pharmacotherapy, psychotherapy, or behavioral techniques. In general, we can confirm that emotional support and understanding offered by the medical staff is crucial for the patient, irrespective of the kind of treatment or therapy applied. An honest and equal relationship between physician and patient itself is able to reduce the patient's anxiety. Psychopharmacotherapy for cancer patients is special in several aspects. When planning such a therapy, we must consider possible interactions between psychopharmacologic medications, cancer, and chemotherapy agents. For example, anticholinergic effects of various drugs may cause ileus. Smaller doses in the initial phase of treatment should be increased gradually in the forthcoming stages. Even the stabilizing dose of medication given to cancer patients is usually lower than those used in healthy individuals due to altered metabolic states. Considering that anxiety is one of the most common psychological components of cancer, about 1/3 of patients receive anxiolytic therapy as part of their hospital care. Anxiolytics are required not only in the treatment of severe intrusive anxiety. The most commonly used medications are the benzodiazepines. These medicines can even be applied when side effects like nausea and vomiting or anticipatory nausea and vomiting appear. Patients with chronic insomnia should be administered anxiolytics instead of sedatives, since insomnia is most commonly caused by the distress and worry related to cancer. Benzodiazepines are the most commonly used medication in the treatment of acute anxiety. Nevertheless, they should not be used for longer than 3 weeks continuously, as they may be habit-forming. 3 of the most popular ones are alprazolam, lorazepam, and clonazepam. These drugs have been shown to be effective in reducing anxiety. An initial 0.25 milligram dose of alprazolam can be increased to 1 milligram administered twice a day. This medicine has proven effective in alleviating nausea and vomiting as well as some depressive symptoms. The major advantage of using lorazepam is the fact that it has shown no metabolic side effects. This means it can be used in the treatment of liver cancers or metastases as well. The recommended initial dose is 0.25 milligrams with the highest recommended dose of 2 milligrams administered 3 times a day. In this case, however, the sedative effects of the drug might appear as well. This in turn is beneficial for anxious states accompanied by psychomotoric restlessness. Clonazepam is recommended in the treatment of chronic anxiety. It is a medication that may take some days to carry out its full anxiolytic effect, with doses of about 1 to 1.5 milligrams a day. Therefore, it acts longer. Here we could only give an outline on the use of benzodiazepines in order to assure that the ideal medicine is chosen and that it is available. Local prescribing guidelines or hospital formularies should be followed in different countries. Anxiety is often accompanied by depression or other psychiatric disorders. When selecting a certain anxiolytic drug, we shall aim at the least possible medical interactions and side effects. Conventional tricyclic and tetracyclic drugs like amitriptyline, imipramine, clomipramine, or proline may reduce depression and anxiety at the same time, yet with numerous side effects appearing. Antidepressants like amitriptyline and clomipramine that carry out their effect, at least in part, through the serotonergic system, have analgesic properties as well. These drugs are best administered when we can suspect severe pain as the background of anxiety. When anxiety is accompanied by depression or panic disorders with or without agoraphobia, the SSRIs appear to be the best choice. The major advantage of drugs like citalopram, fluoxetine, paroxetine, or sertraline is their lack of anticholinergic, antihistaminic, and anti-alpha-adrenergic effects. This makes these medicines easily tolerable for cancer patients. Confusion is a possible symptom of cancer in this treatment. This may be effectively treated with butyrophenones. Small doses of haloperidol, up to 3 milligrams a day, may reduce confusion, paranoid ideas, or hallucinations. Ava, 45, works as a librarian. She was diagnosed with breast cancer in 2001. She had several losses to suffer preceding the onset of the disease. She had moved from Transylvania to Hungary. Her father died in 2000, and her younger son had severe abrupt pneumothorax. Partly because of these events, she hesitated to consult a physician, even though she had found a nodule in her breast earlier. Following her operation, she received chemotherapy and radiotherapy. She asked for psychological help because of her anxiety, worry, and fear that showed after the completion of treatment. Her treatment consisted of 2 parts, a pharmacologic one using benzodiazepines and psychotherapy. In the course of the therapeutic sessions, she revealed the burden that had had filled her with guilt. At the same time, it was this traumatic experience that made her doubt the possible benefits of a therapy. Eva was 11 when her mother, 42 at the time, just like Eva at the time of her treatment, fell ill. The treatment her mother received consisted only of an operation, since there had been no other possibility of treatment in their neighborhood. Within the following 2 years, metastases developed in her bones and her lungs, which caused severe pain. She received morphine treatment that had to be administered by her 11-year-old daughter, our patient. Eva was worried to have mismanaged the treatment, and by that having caused her mother this severe pain herself. She had been nursing her mother alone, so she had to quit school for half a year. Ever since her mother died, she had been very afraid of disease and pain. She had no trust in her recovery with such a recrudescence. Her anxiety reached a top at the completion of treatment when she had lost the protection of chemotherapy. Her long psychotherapy consisted of 3 different phases. These phases had been determined by feelings of an increasing anxiety relating to repeated medical examinations. Her personality and her attitude towards other people had changed significantly. It seemed that she had come to comprehend the connection between her own attitude towards the disease and the disease of her mother. She had given up the part of the subordinate martyr that she had been playing. This part seemed to have been motivated by a need for penance. For 3 years she had been tumor negative and has ever since had a good quality of life. Cancer patients may require psychological treatment when anxiety and emotional lability make it impossible for them to cope with their situation alone. As a second precondition, they have to be motivated for psychological support. It is usually applied as supplementary to pharmacotherapy. Verbal as well as nonverbal therapies might be useful. Most of these psychological methods aim at reducing anxiety and enhancing the patient's coping strategies, as well as dealing with his or her current intrapsychological and interpersonal conflicts. Psychological treatment has been shown to be effective in numerous studies. Individual and group therapies, behavior therapies, and relaxation therapies may significantly lower patients' level of anxiety. Therapies may vary greatly in their duration from short to long-term treatment. When recognized in an early phase, the symptoms of anxiety may be effectively reduced by short interventions within the course of a few therapeutic sessions. Any therapeutic forms has to be considered the patient's current somatic state, which requires great flexibility. In the following, you hear the case of Marika, 66. I'll allow you to read that for yourselves. These methods are very effective in reducing anxiety and moderating depressive thinking. The rationale of this therapeutic intervention is to first identify bad or inadequate thoughts and unrealistic fears. Then, by understanding, accepting, and eventually reframing these, we can gradually confront them with reality. The first simple steps may already help a lot, considering that many of the patients had been left alone with their problems. There is rarely anyone they could share their troubles with, so they tend to overestimate the significance of their symptoms. The model developed by Murray and Greer, along with cognitive therapy worked out by Beck, might be able to reduce depression and anxiety. A therapeutic intervention of no more than 6 to 12 sessions might already be effective. Such techniques can also help in preventing recurrence, dealing with strong fears related to death or dying, as well as conceiving realistic plans for the future. Structuring the day by planning various programs and activities helps to get out of the circulus vitiosus of bad thoughts that center around the disease. Cognitive therapeutic interventions require the client's active participation, and they may significantly enhance the client's consciousness and sense of control and quality of life. Anxiety, distress, physical symptoms related to cancer might be effectively treated with a wide range of behavioral techniques. The beneficial effect of relaxation on psychosomatic disorders has been known for a long time. Cancer patients suffering from anxiety during the entire course of the disease often develop physical symptoms like nausea, vomiting, muscle tension, or pain. These symptoms can be effectively reduced by progressive relaxation or diaphragmatic breathing. Imagery techniques might be applied along with others to relieve symptoms of anxiety related to cancer. Imagery, meditation, or hypnosis can all be effective in producing a relaxed physical state. Fears and phobia related to treatment, as well as anticipatory nausea and vomiting, might be successfully treated with systematic desensitization. The rationale behind this technique is to first have patients imagine the various stimuli that trigger fears and vomiting. Then they have to imagine the process of treatment repeatedly before experiencing the desensitization process in vivo in the course of the forthcoming treatment. All sorts of techniques mentioned above have to be regularly practiced at home. This ensures stability and security that persists beyond therapeutic sessions. Another well-known and frequently applied method of reducing anxiety is supportive psychotherapy. In the case of cancer patients, this form is very similar to crisis intervention. The structure of the patient's personality might become looser. They might fall into a deep regression. Emotions are more easily stirred up. Focal problems are more likely to come up, like the disease itself, treatment, a fear of future events, changes in patients' everyday life. Patients tend to consider the therapist omnipotent and establish unrealistic claims towards him. They might idealize the medical staff as well as the entire intervention. When starting the therapeutic process, it is very important to assess the patient's motivation, expectations, and psychological state. It is also important to measure the degree of their anxiety and depression, as well as their coping mechanism and their mechanisms of defense. The therapeutic contract in situations of acute crisis usually contains an agreement on a short focal intervention with a fixed number of sessions. After completing a certain phase of treatment, the patient's psychological condition has to be reassessed. The fixation of certain symptoms, a persistent feeling of anxiety, might warrant the continuation of the therapeutic process or an interrupted treatment done in separate phases. Besides individual therapy, pair, group, or family therapy might help in addressing interpersonal components of anxiety. Peter is a young man of 22 years with a seminoma. He goes to university, plays football. He felt the tumor after a sport injury. Cancer seemed completely incredible and unacceptable for a young man who had been absolutely healthy. He came to accept treatment, although with great resistance. During the first 2 cycles of treatment, he felt only a little nauseated. At the third treatment, however, he showed strong nausea and vomiting, malaise, strong pain in his limbs, and weakness. He decided not to have the medications of the 4th cycle administered. When he received a phone call from the hospital reminding him of his appointment for treatment, he started to feel sick and nauseated. He felt incapable of continuing treatment. Since each time he even thought of it, he felt sick. Skipping 1 cycle following relaxation treatment, he was able to resume chemotherapy. Before he entered chemotherapy, we started a benzodiazepine treatment, which helped lower his level of anxiety and fears relating to treatment. As already mentioned in an earlier slide, these psychological symptoms are usually underestimated. This is partly because many patients have trouble asking for psychological support. In some countries, the inability to cope with the disease is considered shameful. By now, we have fully developed tools in our hands that are able to assess distress and can be used as simple screening measures. The distress thermometer is a simple pen and paper device easy to use for any patient. Other widely recognized tools for the assessment of anxiety and distress are the HADS, the Zung scale, the Beck and Hamilton tests. Anxiety and distress might be easily assessed, and based on the scores, patients may receive the kind of psychological support they need. These screening devices should be available in the entire oncological care to make sure that cancer patients receive the psychological and social support they need. In summary, anxiety and adjustment disorders are the most common psychological symptoms in cancer patients. The diagnosis of the disease represents a life threat. It means insufferable symptoms and treatment, significant changes in their way of life, and painful losses. Anxiety and adjustment disorders are, as mentioned, the most common psychological symptoms that should be recognized and treated as early as possible. A compound treatment with psychopharmacological and psychological techniques is likely to reduce distress and improve quality of life. One of the objectives of this webcast lecture is to help cancer patients receive the psychological support they need. Thank you. You have just completed a lecture from the IPOS online curriculum, which has been generously supported by the European School of Oncology. If you have further interest in joining IPOS or in learning more about the European School of Oncology, please contact the organizations directly. At this time, we hope you will complete the course evaluation, which is provided as an attachment to this lecture and may be found on the right-hand side of the top bar above the slides. Please complete the evaluation and fax it to the IPOS headquarters as instructed on the form. We hope that you have found this lecture to be useful and informative, and that you will continue to take all the lectures as they become available. Thank you.